There are two documents people are talking about. One is IQCP, a step-by-step guide developed by CMS in the United States, and the other is EP-23A, a laboratory quality control based on risk management. This is a regulation for people in the United States. In light of advances in technology, CMS has adopted a risk-based approach that they call individualized quality control plan. Portions of the EP-23A document capture the principles of what they want to do. This EP-23A provides guidance on how to meet these regulations. It also provides guidance on how to manage risk in general in labs. You must do IQCP, you should do risk management. There are two new things that these introduce. One is, at the least, the ability of the QC procedures to detect medically allowable error should be evaluated. For the first time, you have to QC the QC process. They say the same thing in IQCP. Remember, quality assurance is used to determine if the quality activities you have put in place are working. Are they doing their job? And part and parcel of making that decision is the frequency of QC sample procedures must be designed to have a high probability to detect a stated medically allowable error. Very clear guidelines. Risk management is actually black and white. You have, it is or it isn't. It's a remarkably clear process. Risk evaluation is the process of comparing the estimated risk against given risk criteria to determine its acceptability. So you set an acceptable risk level, you measure the existing risk, and you answer the question, is risk acceptable, yes or no? Here's the trick though. It's not your call. That question, is risk acceptable, yes or no, belongs to these people now. Acceptable risk is defined as a state achieved in a measuring system where all known potential events have a degree of likelihood for a level of severity of an adverse outcome small enough such that, when balanced against all known benefits perceived or real, patients, physicians, institutions, and society are willing to risk the consequences. I must admit, the first time I read it, my thought was, and why don't they throw in world peace? This is obscure, this is impossible. It is perhaps a tad obscure, but it is not impossible. The best analogy I came up with is they test fire alarms, don't they? There is a risk of catastrophic harm from fire. Because we know that risk exists, we identify fire hazards, we conduct inspections, we do everything we can to prevent them, we train people. We don't stop there. We install a fire alarm system. So if all this preventive measure doesn't work, we still install an alarm to catch a fire if it does break out. And we don't stop there. We test the fire alarm and we hold fire drills. Take that into the clinical lab. There is a risk of catastrophic harm from medically unreliable results. You identify the hazards that can cause unacceptable patient risk. You carry out inspections, you do method validation, you do routine maintenance, you do proficiency testing, you send your key operators out for training, you do everything in the world you can to prevent that risk. But in case there is a problem, you use instrument built-in quality control, patient QC, and stable sample QC are the tools that you have to make sure that risk does not exist. And now you can't stop there. At the least, the ability of QC procedures to detect medically allowable error should be evaluated. When you've done that, then you have acceptable risk.